So the topic is tailoring therapy based on disease duration. Is there a window of opportunity? And honestly, when I saw this, I gasped. I said, everybody knows this. What are we talking about? Why am I doing this? So I'll tell you why I'm doing it eventually. But when I first said it, I said, give me a break. Okay, what is a window of opportunity? That's the first question. So let me define for you what a window of opportunity is, in case you didn't know. So a disease much more amenable to treatment within the window. No surprise. This is the important one. Treatment within the window that can reset the disease long-term and transform it in a way that treatment outside the window cannot. And that's the critical piece. And finally, some have said, in fact, we've heard it today already, there's no point in which the window closes, but earlier is better. So really the theme here is earlier better, or is there, in fact, a defined window of opportunity? And that's the question. So I'm going to answer 3 questions, and here they are. And on Monday, anybody who's of the Jewish faith will be able to answer 4 questions. But today, we're just answering 3. What's the evidence for earlier treatment? That is there evidence? What's the evidence for a particular window of opportunity? And is there histological evidence supporting a window of opportunity? Those are the 3 questions. Okay, what's the evidence for earlier treatment is better? And the truth is, my mother can answer this question. I know that. And everybody in this room can answer this question, but I thought I'd give you at least a few little excerpts that provide the data. So here they are. Was one of the first trials by Lard in 2001. And basically, he had 2 populations of patients, each about 100 patients each. And there was what called a delayed approach. So you couldn't use a DMARD after 3 months. You had to wait 3 months, NSAIDs first. And the other one you would add in 2 weeks. So one waited 3 months, one used it in 2 weeks. And the question was, in that differential period of time, is there really a difference in the response? And here's the result. This is the radiographic data. And this is exactly actually which was shown this morning. And it's really interesting because it says that even between 2 weeks and 3 months, if you treat that early, there is a difference. And radiographic progression occurs, and it continues on a trajectory which is different than the early, that 2 weeks. So the 3 months continues to rise, the 2 weeks goes up and flattens. So that's the important concept, because it kind of says it is resetting the way or the course of rheumatoid arthritis, at least in terms of destruction. So that was the first trial, or at least one of the first. The second one actually was one by Neil, and in this trial it was a little bit different. I like his definitions. He had very early RA and late early RA. Anyway, very early RA means that he would treat people within 3 months, and he had about 40 patients, 2 separate groups of 20 each, versus another group of 20 patients, not a big sample size, in which you could be treated between 9 months and 3.5 years. And the question then was, is there really any difference if you treat early, under 3 months, or even between 9 months and 3 years? And so this data is a little interesting because it's different than the data from Lard in terms of what happened. So here's the results. The black dots are those people who treated early, under 3 months, or late, and then the early ones were the white dots. You see a rapid improvement, but notice that once the disease plateaus, it stays the same. And then the next slide is a little different than Lard. That's the important one. So here you see that the early folks flatten quickly, under 3 months in terms of radiographic progression, but the later group, it rapidly improves, but it doesn't have a trajectory that continues. In fact, if you look at the trajectory, it's virtually the same as early disease. So I was a little surprised by that because I expected the trajectory to continue, as other studies have shown. In the COBRA trial, for example, we saw the same thing, although it wasn't duration, but it was obviously aggressive therapy. But this flattened out, and I'm not sure why there's a difference between this study in terms of the trajectory versus the early study by Lard. So then you say, okay, That's only 2 studies. Let's get a whole bunch of patients together and let's see what happens to the response to therapy if the trials or the patients were early, that is early trials versus later trials in terms of disease duration before the trial began. So they really took about 14 trials, randomized trials, looked at second-line therapy, mainly conventional therapy. These aren't much in terms of biologics, and the response was evaluated simply. The question was, what proportion of patients achieve at least a 20% improvement in each ACR core set? That was called improvement. And the disease duration was looked at, but they also looked at a number of other things. They looked at prior DMARDs, functional class, disease activity, gender, and patient global. But at least disease duration, remember that's my question, was one of the questions. Does disease duration matter in terms of response? So here it is. There's the result of all the 14 trials in terms of each one of the ACR outcomes. And you can see to the left-hand side, 0 to 1, 2 years duration of disease in terms of the response, much higher response or improvement. When you look later out to 10 years, you can see the later trials show much less of a response in comparable disease-modifying drugs used. So there was a difference earlier versus later, and this was the whole scene in terms of 14 trials. So it's not just 1 trial, 2, it's actually 14 trials. So then they said, okay, this is 20,017. In fact, it was 20,006. Let's do a meta-analysis, because a meta-analysis will really tell us, when we use all these trials together, whether truly there is a difference in earlier or later. So in this one, they actually looked at 12 studies from the unpublished and published literature, as they do, and they examined basically the association with the delay in treatment initiation and damage, radiographic progression. And they looked at all trials actually initially, under 2 years duration, and the difference in the annual rates of progressions were evaluated in those that are early and in terms of delayed therapy, and they used what's called the standardized mean difference, SMD, to look at the difference between those that were delayed and those that were early. The delay, in fact, was only about 9 months. But if you looked at all of these 12 studies, there was only a difference of about 8 or 9 months in the onset versus the delay in these trials. And here's the results. And all you notice, if you find the 0, I'll find the 0 for you. There's the 0, which means no change. And then you see most of the trials showed actually a decrease in radiographic progression. And the standardized mean difference was about 0.2, and that equated to about a 33% difference. So the message is in all of these trials, on average, there was a 33% reduction in radiographic progression if you treat on an average, we'll say, of 8 months difference in terms of disease duration. So again, that's the whole spectrum of trials, not just 1 or 2. So it's looking pretty good that earlier is better, and as I said, my mother could tell you that anyway. Okay, then suddenly a paper came up, and it turns out it was mine, and I had forgotten. I said, oh my God. I looked at the literature and I said, Keystone, who the hell's he? I thought it was my brother, but it turns out it was me. And it turns out I actually did a study on earlier versus late. And there aren't many studies of these, very surprising. So the issue is here, we did a subset analysis, not very scientifically rigorous. That's the big problem. We took a group of patients, 50 patients in the DEO-19 trial. You know, there was this trial, that trial, and everybody had a name on it. And then they had my trial, DEO-19. You know, why didn't I get a nice name? I didn't. I got DEO-19. What can I do? So they had trials under 2 years. These are patients under 2 years and this is adalimumab trial. And those patients that were more than 2 years of disease, and they asked the question, was there a difference in response? And you can see the ACR 20-50-70 was pretty good. If you were under 2 years, 70-60-40. And then after 2 years, it was 60-40-18 or 60-40-20. So therefore, there was a difference early versus delayed. There are very few analyses by these, by most folks, probably because they're not as rigorous. Remember, there's subset analysis, post-hoc analysis. When you look at the tender joint count, what percent had 0? Well, those that were early, 25%. Those that were late had 9%. And those with a 0 HAC score, which is pretty good, was 40%. Has 0 HAC under 2 years, and late disease only 15%. So the message here is, even with biologics, if you look at the, quote, not so rigorous analysis, there seems to be a difference between early and late disease, at least in terms of duration of disease and treatment. So there appears to be a window of opportunity. I said appears, notice. So the ultimate question, and this is the question, is there a defined window of opportunity, i.e., is there a window that closes? So once it's closed, you can't do well because there's a certain period where you do well, and then after that period, you can't do well. Or, question, is earlier just better than later? The earlier you treat, the better, no matter where you are. And that's kind of an important question from a biologic point of view. So there is one study, a little complex, and the study is by a fellow named Van Nuys, and he evaluated the relationship between the symptom duration before therapy and the persistence of remission. That is, absolute remission, drug-free remission. Now that's kind of surprising. This is 2015, and these are conventional treatments, and the suggestion is you can have people who have long-term disease-free remission. Wow, that's fantastic long-term, at least a year to 5 years. And he asked the question, does it matter how long it takes to treat them to get patients who end up having long-term 1 to 5 years of disease remission? So here it is. So they had 2 cohorts. One was from Leiden, 738 patients. It included patients who were under 2 years of disease, no prior DMARDs, and the patient became included the minute they started a DMARD. So you looked at the time from symptom onset until DMARD, and that became the duration. You looked at the Aspire. I'm Canadian, so I say it French. Aspire. It's the only French word I know. I'm a Canadian, but, you know, don't ship me south, keep me in the north. So then the Aspire trial, there were 533 patients, again a longitudinal group, another cohort, a second cohort. Now we have 2 cohorts. They had to come on with at least 2 swollen joints over 2 weeks, but they couldn't have it more than 6 months. So they had to be less than 6 months. And the disease, the DMARD initiation was then the time in which the duration was considered. So duration of symptom was defined as duration from the first symptom of the patient until inclusion in the cohort. So the primary outcome was DMARD-free sustained remission. DMARD-free sustained remission. We never see that. I know that 14% of patients in all the studies find that, but this is DMARD-free sustained remission, and that means no swollen joints, 0 swollen joints for at least 1 to 5 years. That's amazing. Then they looked at the probability using hazard ratio of the disease-free remission during that 5 years to correlate with, quote, what I just told you is symptom duration. They said, okay, what's the duration of symptoms and how does that correlate with DMARD-free remission? And the secondary outcome they used was radiographic progression. So the median symptom duration in these studies were 18 weeks in one and 21 weeks in the other. So that's pretty quick, but remember this is from symptom onset until use of DMARD. The patients were treated with 67% were methotrexate or sulfasalazine. The other group was 76%. The interesting thing is, and not surprising, DMARD-free sustained remission was only seen in one cohort in 11%, and the other cohort was 4%. So immediately you say to yourself, give me a break. The sample size here has to be small because there aren't that many patients who had DMARD-free remission. So there's a flag that I think about in this study. So here's the results. At the top, what you see is the symptom duration plotted against time. So there's the hazard ratio of patients or percent of patients that are going to get into DMARD-free remission. Early on, the curve is high, which means a high percent will get into DMARD-free remission. And over time, over the 40 weeks, fewer and fewer patients will get into DMARD-free remission. So time is a factor because the longer it takes to get on the DMARD, it looks like you're not going to do as well. Interesting, the curve is curved, it's not linear. It's not linear. So there's not a direct relationship in a linear, but over time, there seems to be fewer and fewer people making it, suggesting maybe time is an issue because it's not coming down flat, it's not coming down vertically, it's now flattening out. And then if you look what's called the time-dependent ROC curve, which is receiver operating curve, and you look at the validity of the relationship between the symptom duration and disease-free remission or DMARD-free remission, it goes straight, which is okay, but then it turns. And the importance, so there is some difference at some point. The curve doesn't continue up, saying there is something happening. So it's maybe over time there's now a difference. But the problem is that the ROC curve, area under the curve, is 0.61. And as I would say, the relationship between symptom onset or symptom duration and remission, using the ROC curve, quote, as my kids would say, sucks major. A 0.6 means not such a good relationship. It's not very rigorous. That's a problem, a big problem, because if it was good, then you can say a lot more. They then looked at it in the Aspire cohort, got exactly the same results, but interesting again, after a certain period of time, like about 18 weeks, the curve actually flattened, which means you couldn't continue to have more patients in disease-free remission. So it looked good for the first while. Early on, more and more patients were getting into disease-free remission, but suddenly, at a certain point, it stopped. It was no longer a linear curve, it flattened out. Again, the ROC curve, area under the curve, was only 0.59. Again, as my kids would say, not so good, Dad. This ain't so good. So there wasn't a great relationship. Even when they looked at radiographic progression, and they looked at the probability of progression with disease duration, instead of having a linear straight line, that is, the longer the duration, the more likely progression, it flattened again. That is, over time, it turned out that it didn't matter what time, let's say after 20 months, you couldn't get any better. That is, you actually flattened the curve. So it was no longer a simple relationship saying something happened somewhere along the line, let's say at 15 or 18 or 20 weeks, which says that radiographic progression changed. There was something different to the patients over time, suggesting that there was a window of opportunity because, in fact, something different was happening radiographically and clinically after a certain period of time. So, conclusion, there appears to be a defined window of opportunity between 15 or 20 months. I said maybe based on the data. The low rate of prolonged remission, that is, I said 11 and 5%, says, that's not very good. And the low area under the curve and the ROC curve says that the curves, it raises the question of the validity of the relationship between the symptom duration and remission, because those ROC curves were not very good. So, that's a comment. Is there histological data to support a window of opportunity? Now let's look at the tissue. Could there be tissue evidence of that? So there was one study by Raza who he looked and he characterized the cytokines in patients seen under 3 months, less than 3 months. He did synovial fluid analysis and looked at all the cytokine profile. He followed them for 18 months, and at the end of 18 months, he said, put up your hand if you're rheumatoid, put up your hand if you're psoriatic, put up your hand if you're non-RA disease. And he asked the question, could you actually look at differences between early disease and established disease in relationship to what's happening to the cytokine profile? So was there a difference early versus late? And maybe that might suggest the possibility that there could be a window because early is different than late. So he looked at under 3 months. I said that, followed them to 18 months. And then he said, oh, you're either crystal disease. In other words, you're either OA or you're a non-RA or non-RA persistent disease. So here's the results. Just look at them, you eyeball them. Now there are 5 little lines across, bars we'll say. The first one on the left is the early RA group. That is the group of patients when they did the fluid turned out to have rheumatoid. The next group, that is number 2, I've got little arrows there, minor arrow side. Number 2 says those patients that were non-RA inflammatory. The fifth group there are established RA. So you've got those that went on to early RA, those that went on to non-RA, and then you have those that are established RA. In the middle, there's people with crystal disease and OA. So the 3 main groups are early RA, late RA, and those that weren't RA but had a persistent disease over that period of time, over the 18 months. So notice, I'm going to go back. Notice It doesn't take a person to notice much. First of all, IL-2 looks pretty good. Those are patients who eventually went on to RA. IL-4 looks pretty good. All the rest are 0. IL-13, not so good. IL-15, pretty good. EGF, pretty good. BGFGF looks pretty good. Echo, I can't even read it, but I'll read it here. Eotaxin, whatever that is, not so different. And gamma interferon, not so good because these are the non-RA persistent disease. Non-RA persistent, the RA didn't have anything. So there were a few cytokines that seemed to portend to rheumatoid versus those with inflammation of non-rheumatoid or even in those with established disease. And they did a whole bunch of other cytokines, and the only two I can comment on here are IL-17 down here, which looks pretty good. Those are the patients who developed RA. And the other one up here, which is IL-1 beta, which is of interest. Notice again, IL-1 beta looks good compared to all the others, and IL-17 seemed to portend RA compared to any of the other conditions. So at the end of the day, he also looked at what happens over time. So look at the black dots. These are patients who eventually turned out to RA. And over time, that's early, but as you went later, the black dots were lower. And here, this is with IL-2, this is IL-4, lots of black dots up here high in early disease, but over time, the black dots disappeared. That is, they became lower. So there was a difference between very early and later, even though they became RA, it was at a time that the cytokine was highest in the, which portended for RA here, but over time, those cytokines that were here became lower, if not 0. So, a distinct transient synovial fluid cytokine profile of T cells and stromal cells observed in early RA were distinct from established RA. They were distinct. I showed you the whole ones that were distinct, and that was compatible with the possibility. Remember, earlier versus established, it was consistent with the possibility that there was a window of opportunity. Unfortunately, it doesn't prove it because it's also consistent with earlier is better in terms of response to therapy or response to treatment. Finally, synovial tissue. We did the fluid, now we do the tissue. So what happened? They looked at folks in early disease, either less than 1 year, they biopsied them, or patients over 5 years, and they said, what do the cells look like in the synovial tissue of patients early versus late? Less than 1, greater than 5. If you look down the numbers here, just you look at them, they're almost the same. There's almost no difference in terms of lymphocytes, plasma cells, so that didn't make much difference. And then you say, okay, what about the cytokine profile? Well, you can't read this slide, but trust me, I'm a doctor, and it says here, basically, that the profile here, histologically, was exactly the same in patients under 1 year and greater than 5 years. So that says that immunologically, at least in one study only, the histological features in early versus late disease was no different. So far, you couldn't say that it does explain a window of opportunity. Finally, what have we learned? Treatment earlier is better. Clinical evidence may support, I say may support, a window of opportunity with the caveats that I talked about. A distinct transient cytokine profile seems to be maybe in keeping with either, but in keeping with. That is, it's different earlier versus late. And an immunological histological profile, that was the synovial fluid. The immunological profile, histological profile in the tissues, however, to date is not supportive. So, taken together, do I believe in a window of opportunity? That's the question. Or do I believe that earlier is just better? My answer is yes. You figure out what that means, okay? Because yes means, I don't know. There isn't enough data for me to say one or the other, but there's data potentially for both.